the hip joint is one of the most stable joints in the body, and because of that, it actually takes a very strong force to dislocate it. That's why hip dislocations usually don't happen in everyday life. They almost always happen in younger adults who are involved in high-energy trauma, most commonly motor vehicle accidents. Think about a car crash where the person's knee hits the dashboard. That's the classic scenario. When a hip dislocation occurs, it's never something we can take lightly. In fact, it's considered a true orthopedic emergency. The reason is that the blood supply to the femoral head is at risk. The main artery that keeps the femoral head alive can be damaged, and if that happens, the patient has a very high chance of developing what we call avascular necrosis, where the bone tissue essentially dies. That complication alone can completely change the long-term outcome for the patient. Another point to highlight is that hip dislocations often don't come alone. Many times there are associated injuries, things like cartilage damage, fractures of the femoral head, or ligament injuries around the hip and knee. Because of that, every patient with a suspected hip dislocation needs a complete and careful evaluation. That means a musculoskeletal and neurologic exam, checking the sciatic nerve, making sure circulation to the leg is intact, and of course, proper imaging to confirm what's going on and to rule out fractures. Missing one of these injuries can have serious consequences later on. Now, let's talk about how these injuries actually happen. The mechanism of injury tells us a lot about what type of dislocation to expect. The most common pattern is a posterior hip dislocation. This happens in car accidents when the knee slams against the dashboard while the hip is flexed and slightly rotated inward. That force pushes the femoral head backwards out of the socket. In fact, posterior dislocations are about 9 times more common than anterior ones. If the hip is flexed, adducted, and rotated inward, you're likely to get a pure posterior dislocation. But if there's less flexion or less internal rotation, this same mechanism can cause not just a dislocation, but also a fracture of the femoral head. The head of the femur actually breaks as it hits the edge of the socket. On the other hand, if the hip is extended, abducted, and rotated outward, that favors an anterior dislocation, which is much less common. These anterior types are usually seen when someone falls or during accidents where the hip is forced into an awkward, stretched out position. To give you some mental pictures, imagine a driver or passenger in a car crash with both knees bent and hitting the dashboard. That's the classic setup for a posterior dislocation. Now, imagine someone falling with the legs stretched out and rotated outward. That's the setup for an anterior dislocation. Sports can also be a setting for these injuries, though much less common than car accidents. For example, in football or skiing accidents, the hip can be forced into extreme positions that cause dislocation. Interestingly, research has shown that snowboarders are at a much higher risk than skiers, about 5 times more likely to dislocate the hip or fracture the femoral head. That's because of the way falls happen in snowboarding, with twisting and high rotational forces on the hip. Finally, it's important to understand that not all dislocations are equal. Some patients have subtle differences in their anatomy that make them more prone to dislocation. For instance, having less femoral anteversion or even retroversion can put the femoral head in a position where it's more likely to pop out with certain forces. Similarly, conditions like femoroacetabular impingement, where the ball and socket don't fit perfectly, can also contribute to instability and increase the risk of these injuries. So, to summarize this first part, hip dislocations are always the result of high-energy trauma. They are true emergencies because of the risk to the blood supply of the femoral head, and the exact type of dislocation, posterior, anterior, pure, or fracture dislocation, depends on the position of the hip and the direction of the force at the moment of impact.
When a patient comes in with a hip dislocation, whether or not there's also a femoral head fracture, we have to assume that other injuries are present. Studies show that up to 95% of these patients have additional injuries that require hospital care, independent of the hip itself. And these associated injuries can be serious. We're talking about intra-abdominal trauma, chest trauma, even head injuries. In fact, some reports describe cases where hip dislocation was associated with major vascular injuries, like rupture of the thoracic aorta. Because of this, sometimes the hip injury is actually missed at first, simply because the other injuries are immediately life-threatening. From an orthopedic perspective, the most common associated injuries include fractures of the femoral head, neck, and shaft, acetabular fractures, pelvic ring fractures, and knee injuries, such as ligament tears or patellar fractures. It's easy to understand why. In a typical dashboard injury, the force doesn't stop at the hip. It travels down the limb, and the knee takes a huge impact as well. In fact, nearly a quarter of patients with posterior hip dislocations also have significant knee injuries, and unfortunately, many of these are missed in the first evaluation. Because of this, we have to approach these patients with extreme caution. Until we've cleared the spine radiographically, we treat them as if there may also be spinal trauma. The clinical presentation usually gives us a clue. In posterior dislocations, the leg typically sits flexed, adducted, and internally rotated, while anterior dislocations present with the leg held in abduction and external rotation. And any attempt to move the leg, especially rotating the hip, causes excruciating pain. Now let's move to some examples. Imagine a patient comes in after a car accident with a knee injury and the leg shortened, flexed, and internally rotated. That posture immediately raises suspicion of a posterior hip dislocation. Radiographs confirm the suspicion, and if we look closely, we might also find associated fractures, like femoral neck fractures, that completely change how we approach treatment. The presence of associated fractures is critical because it dictates both the timing and the way we can treat the hip dislocation. For example, if there's a non-displaced femoral neck fracture, that fracture has to be identified and stabilized before we attempt to reduce the hip. Otherwise, we risk making the fracture worse during manipulation. This is why careful radiographs and sometimes even CT scans are essential before attempting closed reduction. Pelvic ring fractures complicate things even further. In many cases, they make closed reduction impossible, forcing us to do an open reduction. Similarly, acetabular wall fractures or femoral head fractures can make the hip look congruent after reduction, but in reality, the joint remains unstable and requires fixation. These are the cases where careful judgment, fluoroscopic evaluation, and sometimes even immediate surgical fixation are necessary to avoid long-term complications. So how do we recognize these dislocations at the bedside? The physical exam is very telling. In most posterior dislocations, the affected leg appears shorter and the foot points inward due to internal rotation. Sometimes there are large bruises across the thigh, abdomen, or knee, hinting at the force of the injury. A meticulous neurologic and vascular exam is also mandatory. We need to check for sciatic nerve injury, which is not rare, and for vascular compromise. Anterior dislocations, on the other hand, look very different. The leg is usually abducted and externally rotated. And while these are less common, they can also cause injuries to the femoral nerve or vascular structures in the groin. Radiographs, of course, are the first-line imaging tool. A simple AP pelvis view is usually enough to make the diagnosis. In posterior dislocations, the femoral head often looks larger and displaced upward compared to the opposite side, with the lesser trochanter less visible. In anterior dislocations, the head appears smaller and displaced downwards or towards the obturator foramen. But plain radiographs aren't enough when we suspect associated fractures. In those situations, CT scans are invaluable. They help us detect small intra-articular fragments, subtle femoral neck fractures, and acetabular involvement. Missing one of these details can mean the difference between a stable hip and one that fails early. So at this point, we can summarize. Hip dislocations rarely occur alone. They almost always bring with them other injuries. Identifying those injuries, especially fractures of the femoral neck, acetabulum, or pelvis, is absolutely essential before attempting reduction. The clinical exam gives us clues, the imaging confirms the diagnosis, and together they guide us to the safest and most effective treatment plan.
CT scans are extremely valuable when we're dealing with hip dislocations. Plain X-rays give us the first picture, but CT is what really helps us identify the hidden details, small intra-articular fragments, subtle femoral neck fractures, or acetabular wall injuries that we might miss otherwise. For instance, a difference as small as 0.5 millimeter in the head-neck offset can already suggest an impaction fracture. These details matter because they guide whether we can treat the patient non-operatively or whether surgical fixation is required. MRI also plays an important role, though its usefulness right after the injury is still debated.
MRI can be particularly helpful in evaluating the vascular supply of the femoral head and predicting avascular necrosis. In children and adolescents, MRI tends to be more sensitive than CT when it comes to picking up subtle injuries around the growth plates or cartilage. However, in adults, its role is more selective. Now let's turn to classifications, which are essential in making sense of these injuries. Several systems have been proposed to describe hip dislocations, and the first distinction is whether the dislocation is anterior or posterior. Posterior dislocations are by far the most common, making up more than 90% of cases. Within posterior dislocations, we can go further and use systems like Thompson and Epstein or Stewart and Milford. For example, in the Thompson and Epstein classification, Type 1 is a simple dislocation without fracture. Type 2 adds a large single fracture of the posterior rim of the acetabulum. Type 3 involves a comminuted rim fracture or a rim fracture with a large fragment. Type 4 includes fractures of the acetabular floor. And Type 5 includes fractures of the femoral head along with the dislocation. The Stewart and Milford classification is similar, but places a bit more emphasis on associated fractures. What's important to take away is this: no dislocation is just a dislocation. Almost always there is some degree of associated injury, whether it's to the acetabulum, the femoral head, or the surrounding soft tissues. The classification systems help us organize our thinking, but the real priority is to recognize the injury quickly, reduce the hip as soon as possible, and then plan further treatment based on the associated fractures and the stability of the joint. So, at this point in our discussion, we've gone from the basic mechanisms of injury through the associated complications, imaging strategies, and into the main classification systems. Each of these layers adds to the decision-making process because ultimately our goal is not just to put the hip back into place, but to make sure it heals in a way that preserves long-term function and avoids devastating complications like avascular necrosis or post-traumatic arthritis. Now that we've set the stage, let's focus on the classifications because they drive decision-making at the bedside and in the OR. The most clinically useful system for femoral head fractures associated with a posterior dislocation is the Pipkin classification. Think of the fovea as the landmark that divides the non-weight-bearing part of the head from the weight-bearing dome. In Pipkin type 1, the fracture fragment sits inferior and medial to the fovea, below that equator, so it's typically off the main weight-bearing surface. In practical terms, these are the patients who, after urgent reduction in CT, often do well with either fragment excision, if the piece is small and non-reconstructible, or fixation, if the piece is large and congruent. In the Pipkin figure, panel A depicts exactly this: a posterior dislocation with a small fragment snipped from the inframedial head caudal to the fovea. Pipkin type 2 moves the fragment to the superolateral cephalad side of the fovea. Now we're in the weight-bearing dome. Prognosis gets more guarded because even small step-offs here translate into painful incongruity. These injuries often require anatomic, open reduction and internal fixation of the head fragment to restore the smooth, spherical surface. In the figure, panel B shows that larger cephalad fragment engaging the superior acetabular roof. Imagine the femoral head shaving itself against the posterior rim during the dashboard impact. Type 3 adds a femoral neck fracture to either a type 1 or 2 head injury. This is a high-risk combination. Blood supply has been insulted by the dislocation and now threatened again by the neck break, so the chances of avascular necrosis rise dramatically. The priorities are urgent, gentle reduction, careful handling, and definitive fixation of the neck and the head if reconstructible. In older or osteoporotic patients, arthroplasty may be the safer path. In panel C of the Pipkin figure, you can visualize that line across the neck accompanying the head fragment. The image is a visual red flag for AVN risk. Type 4 overlays an acetabular fracture, most commonly a posterior wall fracture, on top of a type 1 or 2 head injury. Here, stability dictates the sequence. We reduce the hip, test stability under fluoroscopy, and if the joint is unstable or there's a sizable wall fragment, we fix the acetabulum, then address the head fragment as needed. Panel D shows this combined pattern. The posterior wall is broken and a head fragment is present, explaining why the hip will not stay stably reduced without bony reconstruction. Because Pipkin tells us mainly where the head fragment is and what major partner injury exists, some surgeons prefer an expanded framework that also captures stability after reduction. That's where the Brumback system helps. It keeps the dislocation direction and then specifies the head fracture location, the acetabular rim status, and whether the joint is stable after reduction or needs reconstruction. In Brumback 1 patterns, the fragment involves the inferior medial head, the non-weight-bearing portion. Subtype 1A means little or no acetabular rim injury and a stable hip once reduced. Subtype 1B means there is a significant rim fracture, but the hip can be made stable after you reconstruct that rim. Brumback 2 patterns shift the fragment to the superolateral weight-bearing region. Subtype 2A, again, is minimal or no rim damage with a stable joint after reduction, rare in real life, whereas 2B includes a substantive rim fracture and clinical instability, which is the scenario that pushes us toward acetabular fixation plus precise head reconstruction. Brumback 3 flags a femoral neck fracture in the presence of dislocation. 3A without a separate head fracture, 3B with an additional head fragment. This echoes Pipkin type 3 and carries the same message: high stakes for blood supply, so plan meticulously and minimize repeated manipulations. Brumback 4 captures anterior dislocations with head injury and then subdivides the morphology. 4A is an indentation or depression of the superolateral dome, essentially a dent in the weight-bearing cartilage, whereas 4B is a transchondral shear where a flap of osteochondral surface is peeled away. Finally, Brumback 5 labels a central fracture dislocation with a head fracture, the sort of injury where the head is driven medially and the socket and the head are both disrupted. If you look at the Brumback illustration sequence from 1A to 5, you can read the injury logic visually. In 1A, the head fragment is small and sits low and medial. The joint looks concentric after reduction. In 1B, you can already see the posterior rim defect that, once repaired, allows a stable hip. In 2A, the fragment has migrated to the superolateral dome. Even when reduced, you sense how a step-off there would grind. In 2B, the posterior wall involvement widens the joint space and you lose perfect parallelism between head and acetabular arc, an imaging clue to instability. In 3A and 3B, your eye catches the neckline, add a head fragment in 3B, and you're concerned for AVN spikes. In 4A, there was a crater impression on the superolateral head where it impacted the rim during an anterior dislocation. In 4B, the osteochondral shear lifts the flap off the weight-bearing surface, explaining persistent mechanical symptoms if not anatomically repaired. And the 5 image shows the head displaced centrally with associated fracture fragments, a pattern that screens for CT-based planning. For completeness, remember that older posterior dislocation schemes, Thompson and Epstein or Stewart and Milford, were designed to remind us that simple dislocations are rare and that posterior wall injuries are common drivers of instability. Stewart and Milford in particular emphasize post-reduction stability testing when a wall fracture is present, which has clear prognostic implications. Epstein's Vice Type 5 even bundles femoral head fractures into the posterior dislocation scheme, which is why Pipkin subdivision became so widely used, to cleanly separate head fragment location and guide treatment. Modern comprehensive systems like OTA-AO 2018 separate dislocations from fractures and then let you add modifiers. In that language, the hip dislocation itself is coded in the 305 family with a universal direction modifier to say posterior or anterior, while femoral head fractures are cataloged as 31C1 when the head is split and 31C2 when the lesion is a depression of the articular surface. The value of this framework is uniform communication across centers and research, but in day-to-day practice, we still lean on Pipkin and Brumback to decide reduction urgency, surgical approach, and fixation strategy. Once you understand the classification, imaging details fall into place.
After reduction, a CT scan is not optional. It's the tool that shows you those tiny intra-articular fragments, subtle posterior wall splits, and the real geometry of the head fragment. Even a half-millimeter change in the head-neck contour can indicate impaction. CT also lets you judge whether a concentric reduction is truly concentric or whether a loose body is prying the joint open. MRI has a role, but more selectively. It can help in children and adolescents for cartilage and physeal injury, and later it can be used to monitor the femoral head's perfusion, though predicting avascular necrosis in the first days is unreliable. In other words, get great radiographs, then confirm the map with CT before you pick your route. Outcomes after hip dislocation or fracture dislocation are measured both by pain and by function over time. Osteonecrosis and arthritis are the two big threats, one early, one late. That's why we track patients with standardized scores like the Harris Hip Score, or WOMAC, and in younger, active patients, scales like IHOT-33 or IHOT-12 that capture higher demand activities. These scores aren't just for papers. They tell us whether our reduction, fixation, and rehab actually return the hip to a life that includes walking, climbing, working, and sport. Finally, it helps to visualize the pathoanatomy during the moment of injury. For a posterior dislocation, imagine the capsule tearing posteriorly or inferior-posteriorly, while the hip sits flexed and adducted, the rounded ligament can avulse with a bone fragment, and the posterior wall can chip or break as the head leverages out. For an anterior dislocation, the psoas becomes the pivot, stripping the capsule anteriorly and inferiorly, and sometimes denting the superolateral head against the rim. These mental images match the classifications you've learned, where the head strikes, which part breaks, and whether the joint will stay in place once you reduce it. So the practical rule is simple. Reduce urgently and gently to protect the blood supply, obtain high-quality post-reduction radiographs and a CT to define fragments, congruity, and stability. Use Pipkin to communicate where the head fragment sits and whether a neck fracture or acetabular fracture is present. Use Brumback to add the stability and rim story that guides our operative plan. Fix what threatens stability or the weight-bearing surface, debride what is too small to fix, and never leave an incongruent joint behind. That is how classification turns into good outcomes.
When we talk about femoral head injuries, they're most often associated with anterior dislocations. These injuries usually come from three mechanisms: shearing, impaction, or avulsion. Avulsions are the simplest: small bone fragments pulled off with the ligamentum teres. These fragments, if tiny and inside the fovea, are usually not clinically significant. But once we move into shearing and impaction patterns, things become more serious. Think of an anterior dislocation, where the femoral head is forced against the acetabular rim. Instead of the rim giving way, the head itself cracks under the stress. That's a shear injury. The fragment breaks off the anteromedial head, running obliquely toward the posteromedial side. In the CT image shown, you can see this clearly. The fracture line runs about 25 to 45 degrees off the coronal plane, with a free fragment displaced anteromedially. Impaction injuries, on the other hand, are like a dent in the ball, where it strikes the socket, similar to a Hill-Sachs lesion in the shoulder. The articular surface gets depressed, and if that depression sits on the weight-bearing dome, it can create a chronic incongruity that leads to early arthritis. Now let's bring in the OTA-AO system, which modernizes the way we classify these patterns. It separates dislocations from femoral head fractures and then allows us to specify both direction and morphology. The hip dislocation itself is coded as a 30-segment 5. The modifier, in brackets, tells us the direction: anterior, posterior, medial, or obturator. So, for example, a posterior dislocation would be written as 30-5B. Then we look at the femoral head fracture. These fall under type 31C. Within that group, we separate split fractures and depression fractures. Split fractures are coded as 31C1. These are further divided. 31C1.1 is an avulsion of the ligamentum teres attachment. 31C1.2 is a split fracture below the fovea, an infrafoveal break. 31C1.3 is a suprafoveal fracture involving the weight-bearing surface. Depression fractures are grouped as 31C2. These include 31C2.1, which is a simple chondral lesion, essentially cartilage crushed without a large bony fragment. 31C2.2, a depression impaction fracture where the head has a crater-like defect, and 31C2.3, a mixed lesion that combines a split and a depression pattern. In the illustrations, you can see how this coding makes sense. The first row shows the dislocation direction, anterior, posterior, medial, and obturator. The second row shows the different fracture morphologies, avulsion, infrafoveal split, suprafoveal split. The last row shows the depression-type lesions with chondral injury and true impaction fractures. By using this system, we can describe an injury with precision. For example, a posterior dislocation with a 31C1.2 infrafoveal split fracture, and everyone knows exactly what that means. From a clinical perspective, the practical value is in predicting stability and long-term prognosis. Small infrafoveal fragments can often be excised. Suprafoveal fractures, being in the weight-bearing zone, usually require internal fixation to avoid painful arthritis. Depression fractures, if shallow, might be tolerated, but deeper ones can destabilize the surface and often need surgical reconstruction. Biomechanics explains why these injuries occur the way they do. The hip joint is a ball and socket, deeply constrained but still allowing wide motion. Stability is reinforced by the labrum, which makes the socket deeper, and by the thick capsule and strong ligaments. The femoral head itself covers about 2/3 of a sphere, with the cartilage thickest medially and centrally where the weight-bearing load is greatest. Anteversion of the femoral neck and the neck shaft angle influence where forces concentrate. Less anteversion, or forced internal rotation at the moment of impact, favors fracture dislocation rather than a pure dislocation. The anatomy of the capsule and ligaments also plays into this. The iliofemoral ligament, the Y ligament, is the strongest, resisting hyperextension and external rotation. The ischiofemoral ligament reinforces the posterior capsule, and the pubofemoral ligament supports the anterior inferior zone. Together, they restrain the head, but in high-energy trauma, those structures can tear, avulse with bone, or strip off the capsule. The illustration of the coronal section of the hip makes this obvious. You can see the labrum deepening the acetabulum, the capsule enveloping the joint, and the ligamentum teres anchoring into the head. When these stabilizers fail, the head either pops out intact or it shatters, depending on the force factor.
When dealing with hip dislocations, we cannot forget the neurovascular anatomy that lies in harm's way. The sciatic nerve is the structure most often at risk, especially in posterior dislocations. In about 85% of people, the sciatic nerve emerges as a single trunk beneath the piriformis muscle. But in a small percentage, the nerve splits early, or even passes directly through the piriformis. This variation matters because when the hip dislocates posteriorly, the nerve can be stretched, kinked, or compressed against the surrounding tissues. Clinically, this explains why patients sometimes present with foot drop or sensory loss after dislocation, signs of sciatic nerve involvement. Blood supply is equally critical. The main vascular input to the femoral head comes from the medial femoral circumflex artery, specifically its posterior retinacular branches. These delicate vessels hug the femoral neck and are easily torn during a dislocation. If they're compromised, the risk of avascular necrosis increases significantly. That's why every hour counts. The sooner we reduce the hip and restore anatomy, the better chance we have of preserving head perfusion. The anatomical illustrations make this clear. You can see the circumflex vessels wrapping around the neck, entering near the capsule, and forming the subsynovial ring that nourishes the head. Damage that ring, and the head begins to die. Now let's move to treatment principles. The first step, in almost every case, is an attempt at closed reduction. The goal is straightforward. Get the femoral head back into the socket as quickly and gently as possible. This can be done in the emergency department under sedation or in the operating room under anesthesia, depending on resources and patient stability. But the principle is universal. Reduce fast, reduce carefully. Non-operative management is only acceptable if the hip is congruently reduced and stable with no associated fractures that threaten joint integrity. In practical terms, this means simple dislocations or Pipkin type 1 fractures with small, non-weight-bearing fragments that don't block reduction. Once the hip is in place, we confirm with X-rays and CT to be sure the joint is concentric and free of loose bodies. The contraindications to non-operative care are just as important to remember.
if the reduction is incongruent, if there are large fragments inside the joint, if there's a femoral neck fracture, or if we're dealing with Pipkin 3 or 4 injuries, then surgery is mandatory. Leaving these untreated risks instability, arthritis, and collapse of the femoral head. Let's talk techniques. For posterior dislocations, the classic Allis maneuver is widely used. The patient lies supine, the pelvis is stabilized by assistance, and the surgeon applies steady traction in line with the femur, gently flexing the hip to 90 degrees and adding internal rotation and adduction. It's simple, powerful, and effective when done properly. There are variations, like the East Baltimore lift, where assistants help raise the pelvis to reduce strain on the surgeon's back. In both scenarios, the reduction must be smooth, continuous, and controlled. Sudden jerks or forceful movements risk fracturing the neck or damaging cartilage. After a successful reduction, the work isn't done. We need to prove the hip is truly reduced. That means post-reduction X-rays in multiple views, and usually a CT scan to rule out hidden fragments or subtle incongruities. A hip that looks concentric on plain films but hides a loose body in the CT is a disaster waiting to happen if missed. So, to summarize this part, the anatomy explains the stakes. The sciatic nerve and circumflex arteries are vulnerable, and every delay magnifies the risk of permanent damage. Closed reduction is the first-line treatment, but it must be done quickly, gently, and followed by meticulous imaging. And the decision to treat non-operatively hinges entirely on whether the reduction is congruent and stable without fractures in the wrong places.
The reduction maneuvers themselves are worth understanding step by step. For posterior dislocations, the Allis maneuver remains the workhorse. The patient is placed supine on a stable table. One assistant stabilizes the pelvis, pressing down on the anterior superior iliac spine, while another may support the proximal thigh. The surgeon then flexes the hip and knee to 90 degrees, applying steady longitudinal traction. While maintaining traction, the leg is gently rotated inward and adducted, allowing the femoral head to slide back into the acetabulum. It's critical to remember, this is not a brute force maneuver. It's a controlled, steady pull with gentle adjustments. Sudden movements risk fracturing the neck or damaging cartilage. Several modifications have been described to make this safer and less demanding on the surgeon's back. One is called the East Baltimore lift, where multiple assistants share the workload. Regardless of the exact technique, once reduction is achieved, the hip is extended and externally rotated, and a knee immobilizer is applied to maintain stability while post-reduction imaging is performed. For anterior dislocations, we modify the same principle. The Walker technique is commonly used, relying on traction and countertraction. Traction is applied along the axis of the femur with gentle flexion. With a lateral push on the inner thigh, internal rotation and adduction guide the head back into place. If the dislocation is superior, distal traction is added until the head clears the acetabular rim, then gentle internal rotation brings it home. Extension may also be required. The key remains the same: continuous traction, no sudden jerks, and careful manipulation. Once reduction is complete, the job isn't over. We have to confirm that the hip is truly concentric and stable. This is where fluoroscopy plays a role. By placing the patient under anesthesia on a radiolucent table, we can apply controlled stress, flexing, internally rotating, and pushing gently to see if the head remains centered. If it subluxates under stress, the hip is unstable, and surgical fixation of the posterior wall or acetabular fragment is indicated. The images shown in the book illustrate this clearly. In a stable hip, the head tracks smoothly under the socket. In an unstable one, you see the head drift away during stress testing. Intraoperative photos also demonstrate how small posterior wall fragments are repaired. The fragment, often still attached to the labrum, can be reduced back to the acetabulum and secured with anchors or screws. This not only restores bony stability, but also preserves the labrum, which contributes to the suction seal of the hip. Now let's consider outcomes. Historically, the results of closed reduction alone have varied. Data from classic series showed that when hips were reduced promptly, within hours of injury, good or excellent outcomes were achieved in up to 75% of patients. But once reduction was delayed, the rates of avascular necrosis and post-traumatic arthritis rose sharply. For example,
Upadhyay and Moulton reported that 75% of anterior dislocations without head injury had acceptable results, compared to only 48% of posterior dislocations. Hugard's study showed that when reduction was delayed beyond 6 hours, the risk of avascular necrosis increased dramatically. The table of outcomes really drives this home. In Thompson and Epstein's classic series from 1951, 67% of patients had good or excellent results, but 10% developed AVN. Stewart and Milford's series had almost 50% developing arthritis. More modern studies, like those by Yang and Dreinhofer, confirmed that anterior dislocations generally do better than posterior ones, but both groups carry significant risks when associated fractures are present. The strongest message is that time to reduction matters most. Reducing within 12 hours is essential to minimize the risk of AVN, which otherwise rises more than 5-fold. So to tie the section together, the maneuvers are straightforward when done with control, fluoroscopy helps us judge stability, and prompt reduction remains the single most important factor in preserving the femoral head. Surgical fixation is reserved for instability or large fragments, while small, non-weight-bearing fragments can sometimes be managed conservatively. And the long-term outcomes are dictated by how fast we act and how accurately we restore the joint.
When non-operative care is not enough, we move into operative treatment. The main indications are straightforward. When the hip is irreducible by closed means, when the reduction is incongruent because of interposed fragments, when there's iatrogenic injury to the sciatic nerve during an attempted reduction, and in many fracture dislocations, especially Pipkin type 2 or higher. There are two main operative strategies. The first is open reduction with or without debridement, meaning we expose the joint, remove loose bodies or incarcerated fragments, and restore congruency. The second is open reduction with internal fixation, or ORIF, where screws, anchors, or plates are used to secure displaced fragments. The figures here help us visualize the process. One shows an avulsed labrum being repaired back to the acetabulum with suture anchors, restoring the suction seal of the hip. Another shows the capsule after repair, neatly closed and stabilizing the joint. These images emphasize that hip stability is not just about bone, it's about restoring both the bony socket and the soft tissue stabilizers. Now, why do dislocations sometimes become irreducible? Table 52.3 lists the culprits. For anterior dislocations, structures like the capsule, rectus femoris, pectineus, or even the iliopsoas can block reduction. For posterior dislocations, the piriformis, obturator muscles, gluteals, or incarcerated fragments of bone can wedge into the joint. In practice, about 2 to 15% of dislocations are irreducible by closed techniques. CT scans are invaluable in this setting. A fine-cut CT shows us whether bone or soft tissue is trapped inside the joint space. If the obstruction is small and not vascularly threatening, reduction can sometimes be delayed until imaging is complete. But if the head is malpositioned and blood supply is at risk, immediate open reduction is mandatory. Once in the operating room, the surgical approach depends on the direction of dislocation and the fragments involved. Posterior dislocations with associated wall or neck fractures are typically approached through a posterior incision, such as Kocher-Langenbeck. Anterior dislocations, especially Pipkin 1 and 2 femoral head fractures, can be accessed through anterior approaches, such as Smith-Petersen or Watson-Jones. The illustration of the anterior approach shows the interval between the sartorius and tensor fascia lata, giving safe access to the hip while protecting the neurovascular structures. Fixation itself can be challenging. Many femoral head fractures are small, shallow, and located on the weight-bearing dome. Techniques include low-profile headless screws, bioabsorbable pins, or suture anchors. The fixation must be perfectly flush with the cartilage surface to avoid joint incongruity. Subchondral screws are often used, but they must not protrude into the joint. For larger defects, particularly those over 2 square centimeters, bone grafting may be required to restore the articular surface. For example, in Pipkin type 2 fractures, where the fragment lies superior to the fovea in the weight-bearing zone, fixation is usually recommended.
In contrast, Pipkin 1 fractures, with small infrafoveal fragments outside the weight-bearing dome, may be excised if unstable or left alone if stable. Pipkin 3 injuries, combining femoral head and neck fractures, are more complex and often require fixation of both. Pipkin 4 adds acetabular fracture, requiring combined strategies. The surgical outcome depends not only on fixation, but also on preserving blood supply. That's why every maneuver must be deliberate. The MFCA remains the lifeline of the femoral head, and retractors or excessive dissection around the posterior superior capsule can endanger it. So, to summarize this section, operative treatment is reserved for irreducible or unstable reductions or for fractures in critical zones. The choice of approach, anterior, anterolateral, or posterior, depends on the injury pattern. Fixation must be stable, congruent, and flush with the articular surface, using modern techniques like headless screws or grafting for larger defects. And above all, preserving blood supply is the single most important principle guiding every surgical decision.